we go on to the next talk by Dr. Minu MATHEN. Dr. Minu MATHEN does not need any introduction to the AIOS or the APAO because he's an international presence. He's an accomplished and prolific cataract surgeon. He will be talking to us about the IOL centration issues, angle kappa, angle alpha, etc. As a cause of unhappy 6x6 and 6. Over to Dr. Minu.
Thank you, Dr. Soni, for this opportunity. Good morning, everyone. So, IOL centration issues, no financial interest in this. Ideally, IOLs should be aligned to the visual axis. We all know that. And from the title, if we say 6.6N6, he has not mentioned uncorrected 6.6N6. People who have monofocal IOLs also, even with correction, they may be unhappy. We will come to all those. So, we should know that there is a visual axis which goes to the fovea. And there are other axes which is an optical axis and a pupillary axis. So that goes to the center of the pupil. The other one is the perpendicular one which goes perpendicular to the cornea. So there can be an angle between these two. So my talk is actually very simple. With one slide I can stop and finish off, telling that if this angle is more, and we know that this premium IOLs like multifocals and other things are more sensitive to this, and if it is more than this, do not implant, that's all. But then how do we measure all this? You can take corneal topography, aberrometry, pentacam, lens star, IOL master, whichever you have, they'll give you the either in millimeters or in degrees. And if it is around maybe slightly this way or that way, but then still around 0.5, we have to be more careful, see whether the patient is too sensitive and better not to use. See, because there are multiple other reasons. See, capsular bag, see, and zonules, we don't see the zonules at all. So, we don't know how the zonules are. Some zonules may be lax, some bags may be little lax in one direction. So, if we happen to place a IOL in that axis, sometimes it may get decentered, it may contract more. All those things are there which we cannot assess that very well. And then during surgery, if you have a capsular axis which is discontinuous, I would not place a premium IOL or a trifocal IOL. And the size of the rexes, smaller is okay, but then if they tend to phimose, we need to identify them early and treat them, YAG them. And if it is too large, again, the optic can slightly come in front, there can be tilt, there can be decentration. So when we place lenses, all these lenses which any person gets is premium for them. We may think that only some part of lenses are premium, but for the patient, that lens is premium. So let the rexes be centered and very well sized. And during a PC rent, so there are many factors which are acting. So UR tense, management totally changes, outcomes may be different. So I would not suggest these kind of premium lenses when you get a posterior capsule rupture. And they may decenter later. You never know. You place it in the bag. Sometimes small rexes may be converted into a small rent, converted into a rexes may be okay. But then others, if you are not sure, please have a backup of a spherical IOL or a spherical non-premium IOL, non-trifocals. And then post-op capsular bag contraction, as we said, some myopes, some pseudo-exfoliation, some lax zonules, patients who have very shallow anterior chamber and anterior insertion of zonules, very lax bag, thick lenses. All these, if you have a smaller rexes, they tend to contract later, and then there may be decentration. So symptoms, as Matthew was telling, all these kind of unclear feeling, contrast, distortion, glare, blurring, everything. So if it is a multifocal IOL, and if we have placed it, we would like it to be like this. The P1 and P4, when the patient is on topical and if they look at the light source and they have to be matching, and it should be within the central ring of any of your trifocal which we use. So a rexus which is well centered and well sized will look like this. So this is a femto rexus. We can do it ourselves also. So if you mark it properly and size it, see, even now, maybe I have done quite a few cataracts. So I still cannot assess whether it is a 5.25, 4.9, 5.5. Very difficult when you do manually. So marking will be very, very useful for the centration and the sizing. And let me go on to some videos because my talk is over. Basically, centration, decenter, don't place. Angle more than that, don't place. So this is one very old kind of, see, this was the scissors which I used to use for all types of IOLs, but this is a silicon IOL, very old one. So for this I had to use the special one, which is a serrated one. Then see the second forceps which is holding it from the side. So if you want to explant, always stabilize the IOL optic with the second instrument, micro forceps holding it from the side. And this one, actually, both the haptic got disinserted. The optic was lying free. And so we cut the optic and took it out. And after that, and especially in 3-piece IOLs, if they're not coming out of the bag, so try to identify where they are fibrosed and try to move it in an axis or in a direction where it follows the curvature of the haptic. So then you won't tug on the bag, or somewhere there may be some fibrosis. We may not be able to see till the equator. But then fill up the bag with sodium hyaluronate or viscoat and try to visco-dissect and try to pull out in a very gentle and a different angle than what we think it should be, directly tangential, central. That is not the idea. It should be in a direction where it does not induce any traction on the capsular bag. And so this IOL goes into the sulcus and it remains well centered. Just to show you, this is another single piece IOL placed in the sulcus. It's actually flipped also, and it is decentered. So this is another reason for decentration. So make sure that your single piece lenses go into the capsular bag. Mostly if they are in the sulcus, they may get decentered. Nobody knows what is the shape of the sulcus and where it is larger, all those things. So larger eyes, and all these are difficult. But then here again, I just want to make sure that we use viscoelastic sodium hyaluronate, whichever Indian brands, or whichever brands are fine. Get them into the bag, under the IOL, above the IOL, and stabilize the IOL. And if possible, we replace one IOL initially and then cut, so that the PC is totally protected. And towards the end, again, try to avoid cutting the iris and the anterocapsular margin. Be very careful and slowly cut. Don't cut with the tip. Open is slightly wider. This is a regular long tip Vanna scissors, come from any company. And after that, again put in viscoelastic. And then this incision, I will definitely make it make it from 2.8 to 3.2, because it has to come out. There's no point in tugging and pulling. And I know that it can be brought out in a hand-over-hand technique in a 2.8 incision itself. But I don't believe these incisions remain similar after explanting and tuffing. So you see, again, another problem of the malfunctioning of the injector and this lens being shot like a missile sometimes into the bag, sometimes into the sulcus. You can have angle bleed. It can bleed from the ciliary body. It can cause zonular dialysis. It can cause PC rupture. So once we place it inside, if the pupil is not wide enough, just relocate the haptic into this one, into an area which is 90-degree opposite from that, and just retract this one and see. If it is a small PC or a zonular dialysis and it can be left alone, fine. If it is a zonular dialysis, we treat it. I don't want to go into details of this. See, I unnecessarily went into that area and aspirated and got vitreous. So do not just identify. See, if I retract, I can see that small rent area there. And if I rotate the IOL to the 90-degree opposite area, it will remain there fine. So rather than that, don't be too inquisitive to go wherever what has happened and pull on that. You can look at it, but then I had to finally do a vitrectomy. So this is what I want to highlight. Do not be too aggressive in trying to aspirate from wherever you think that there is a small piece in the periphery. So to end, this is the one which is a long-standing one, patient having glare. So this is the one thing. Pupil when constricted, see, it is a little decentered here. There you see fibrosis here. The P1 and P4 are within the optic itself. And if you put a pinhole, patient is happy about it. So here we wanted to size this is the pupilloplasty. There is the lens is very well stuck within the bag and fibrosed. No movement, no pseudophagodonosis. So this is the way I do a pupilloplasty, 4th row pupilloplasty. So take one bite and bring it out on either sides of the pupil and bring it out. Make 4 throws along the loop and then pull it inside. One knot is enough. You don't have to bring it out, make multiple knots. So again, if you feel that it is not small enough, you can make sure that the P1 and P4, especially P1, is within the pupillar area. And we can make one more so that the pupil is small and you don't get the edge of the lens within the pupillar area. And then one more, again to show you 4 throws. different ways of taking 4 throws, but then this is one way to take 4 throws on the loop, and then you can use an Nino or a 10-0 proline, and then with one pull, it just closes down. So if you feel that the pupil needs to be a little more decentered, you can use a vitrectomy cutter to cut the edge of the pupil here, or you can make 2 or 3 snips on the edge of the pupil so that the pupil is slightly larger and the P1 is well centered within this one. So these are some ways of correcting these kind of decentrations, and thank you very much.
Thank you, Dr. Minu Mathan, for that very illustrative talk with a lot of